Okay, today it's my great pleasure to welcome Professor Emma Pierson. Emma is an assistant professor of computer science at the Jacobs Technion-Cornell Institute at Cornell Tech and the Technion, and a computer science field member at Cornell University. Emma develops data science and machine learning methods to study inequality in healthcare. Her work has been recognized by a Rhodes Scholarship, Hertz Fellowship, Rising Star in EECS, MIT Technology Review 35 Innovators Under 35, and Forbes 30 Under 30 in Science. She has also written for the New York Times, 538, The Atlantic, The Washington Post, Wired, and various other publications. And we're delighted to have you here today, Emma. Thank you.
Thank you for inviting me. Can you hear me okay? Perfect. Yeah. All right. Wonderful. All right. Thanks very much for having me here today. It's a pleasure to be here, even though I'm like speaking to you, I think, from like 3 or 4 miles away from a bunch of you, where a bunch of you are based. You'll forgive me as well if I'm occasionally distracted. I have 2 Siamese kittens in the corner who are causing havoc, but their names are Mu and Sigma, so I think they're on brand for a statistics seminar. Today I'm going to be talking about using machine learning to increase equality in healthcare and public health. And to motivate this talk, I'll start by pointing out a couple simple facts. The first is that our society remains deeply unequal. COVID, of course, has highlighted the myriad inequalities that remain, but this is only the latest example of many. Also well known to many of you, I think, is the fact that computer scientists like myself have made this worse in the past, right? And we see many examples of this, right? We see this in language when, for example, models trained to sort of pick up patterns in language through word embeddings naturally also learn undesirable stereotypes like man is to computer programmer as woman is to homemaker. We see this in vision when, for example, this is a picture of Joy Boalamini, who learned that she had to put on a white mask in order for a computer vision system to recognize her face. We see this in healthcare when a widely used algorithm used to sort of predict health risks for patients exhibited racial biases because the algorithm was trained to predict cost as a proxy for health, and Black patients had less money spent on them historically, and therefore the algorithm learned that they were less risky than equivalently sick white patients. And the overall message of all this work is very simple. Algorithms and computer science and data science are no panacea to inequality, and indeed, if used improperly, can even exacerbate it. In this talk, though, I pursue a more optimistic counterpoint, which is that algorithms and data science used properly can also be a powerful tool for combating inequality. And I'm going to try and make this point by sharing 3 stories about how we can use data science approaches to improve healthcare for underserved populations by studying disparities in pain, by studying women's cycles, and by studying disparities in COVID. I should mention that statisticians often like to ask a lot of questions in my experience, so if we don't get through all of these stories, no worries, I'm happy to chat about any subset of them. Let's jump right into it. Let's talk about disparities in pain. This is joint work with David Cutler, Yuri Leskovic, Fenel Melanothan, and Ziad Obermeyer. You can find it published in Nature Medicine in a couple months. So a general fact about pain is that disadvantaged groups experience more of it. You see this for socioeconomically disadvantaged groups across a variety of pain sites, across multiple continents, across multiple sample types. It's quite a robust finding. And you see it for racially disadvantaged groups as well. And this is also true in the condition I'll be telling you about today, knee osteoarthritis. This is one of the most common causes of disabling pain in older adults. Odds are good that multiple people listening to this talk will develop it if they haven't done so already. And mechanically, what's happening is that with the wear and tear of time, the cartilage between the knee bones erodes, the bones get closer together, they grind together, this causes a lot of pain. And in this condition, as in other conditions, disadvantaged groups experience greater pain. You might say, well, maybe they just have worse osteoarthritis. But here's the interesting thing. These groups have more pain even when we control for how severe the doctor thinks their disease is. So I want to make that statement numerically precise for you, but for the numbers to make sense, you have to understand how we measure pain and severity in osteoarthritis. So let's talk about that now. So how do we measure severity? Basically, a doctor, a radiologist, looks at an x-ray of the patient's knee and assesses it on a bunch of clinical features of osteoarthritis, like whether there are osteophytes, bone spurs, how much the joint space between the bones has reduced, and then they summarize all those clinical features in a single number which we call Kellgren-Lawrence grade. This is a categorical scale which ranges from 0 to 4, so it can take on 5 values, 0, 1, 2, 3, 4, where higher scores denote more severe osteoarthritis. How do we measure pain? We ask the patient a bunch of questions. How much pain do you feel when doing various activities, like bending your knee? And then the results of this survey are aggregated into a single number entitled Coos Pain Score. So that's how we measure pain. It's based on the patient's self-reported pain. The data I'll be looking at today comes from the Osteoarthritis Initiative. This is a very widely used longitudinal study of people who either have osteoarthritis or are at high risk of developing it. All the results you're going to see are presented on about 1,300 people, and we're going to be comparing pain by 3 binary groupings. We're going to compare Black to non-Black patients, and almost all the non-Black patients in the dataset are white. We'll compare lower to higher income patients and lower to higher education patients. So what do I mean when I say that disadvantaged patients experience greater pain? Here, what I'm showing you now is a vertical histogram with pain on the y-axis, lower scores, worse pain. And you can see that there is a clear visual disparity between Black patients and non-Black patients. You know, the blue and orange histograms look very different. You want to summarize the size of that gap in a single number, you can just take a simple difference in means. And that's about 10.6 points on the Coos scale. That's a substantial gap, right? You can see it by eye. It's 2/3 of a standard deviation of the entire data set. And this shows the results for income and education as well. You can see that the pain gaps are somewhat smaller, but still statistically significant and substantively large. I've put the 95% confidence intervals in parentheses. So what does that pain gap look like when we control for severity? So if you take a look at the graph at right, you can see now we've plotted severity, that KLG score, on the x-axis, right? So higher scores, worse severity. And we're plotting pain on the y-axis as before. And the important point is that the orange line and the blue line are still not on top of each other. So even conditional on severity, a gap in pain persists. If you want to summarize the size of that pain gap when controlling for severity, the standard way to do so is to regress pain on race and KLG, KLG coded as a categorical variable. And then the pain gap is the race coefficient when we control for KLG. And the results of this numerical analysis are shown in the second column. So you can see that the pain gap for race shrinks from 10.6 points when we don't control for anything to 9.7 points when we control for KLG. So, you know, it gets a little smaller, but it really doesn't get that much smaller, right? It only gets 9% smaller. The overall point being that controlling for severity really doesn't do that much to narrow the pain gap. This is true for income and education as well. This isn't our finding, by the way. This isn't just true in our data set. Other studies find this as well. The goal of our paper is to explain why this is. Why does a gap in pain remain, even when we control for how severe the doctor thinks the disease is? In particular, we're going to seek to distinguish between 2 theories of why this pain gap might occur. The first theory we call the outside their knees theory, namely that there are non-knee related factors which cause disadvantaged patients to experience higher pain even when their knee disease is no more severe. So what might such factors be? Things like higher life stress, less access to painkillers, less social support, etc. Previous research suggests a multitude of possibilities. The commonality here is whatever that it is, it can't be seen in a knee x-ray. It's something outside the knees entirely. And that's why controlling for the doctor's assessment of knee x-ray severity doesn't do that much to narrow the pain gap. But there's a second possibility, right? And that's what we term the in their knees theory, namely that there are pain-related physical features in the knee x-ray, which KLG, our severity score, isn't capturing. And if we could capture those things, we'd be able to explain more of the pain gap. So under the first theory, there is nothing additional to be seen in the knee x-ray. And under the second theory, there is something there that the doctor is missing, but that is pain relevant and that would help narrow these disparities in pain. So why is the latter hypothesis plausible? Here are 2 reasons. The first is that we don't understand pain all that well. This is true in general. Like, you ever go to an emergency room, you will see like a lot of people in pain and a lot of doctors who are quite confused about why they're in pain. It's also true in KLG specifically. It just doesn't explain all that much of the variance in pain. And a possible reason for this is that KLG was developed decades ago in heavily white British populations. And so it's plausible, right, that it doesn't capture all the environmental and occupational factors that are relevant to pain in modern and more diverse populations who live and work very differently. So we're going to seek to assess whether there are overlooked physical features in the knee which would explain the higher pain levels in disadvantaged groups. This isn't just an academically interesting question, by the way, although of course we love academically interesting questions. It's also a question with concrete clinical implications. And the reason is that whether you get knee surgery depends on whether the source of your pain is in your knee. If you go to the doctor in a lot of pain and she looks at you and she says, "I'm sorry, I can't see anything clinically wrong with your knee," then she's unlikely to surgically operate on an apparently healthy knee. She's more likely to prescribe non-specific therapies like opioids or other painkillers. In contrast, if you go to the doctor in a lot of pain and she says, "Aha, I know exactly what's wrong with your knee, very severe clinical osteoarthritis, you're a 4 on the KLG scale," then it's more likely, under clinical guidelines, that she'll prescribe surgical interventions like knee arthroplasty, so knee replacement. Consequently, if our severity scores are missing true physical sources of pain within the knee in disadvantaged groups, these groups may be correspondingly under-referred for surgery. So that's why this matters clinically. Okay, so how are we going to investigate this question? How are we going to look for additional signal in the knee? We're going to train a deep learning algorithm, a convolutional neural network, to try to search for additional signal in the knee X-ray, which could help explain the higher pain levels in disadvantaged groups. Brief digression, why convolutional neural network? I'm not going to go into huge detail about what a convolutional neural network is. Suffice it to say that it's a type of deep learning architecture that performs very well on images. So images in general, starting about a decade ago, convolutional neural networks blew everything else out of the water on sort of image prediction competitions. Subsequently, they've been adopted in sort of a variety of more specialized domains. Most recently, or more recently, medical imaging, where they've often shown very good performance. So the reason we're using this particular algorithm is because if you're predicting something on medical images, basically a convolutional neural network is the only sort of sane or sensible thing you could use at this point. Okay, so we're going to train it to try and look for signal in the knee X-ray. But that's kind of vague, right? What is the actual prediction task? So the standard approach to extracting signal from a medical image is to train your model to replicate the doctor's clinical judgment, which would mean here predicting it, telling it to predict KLG as well as possible. And this is such a standard setup that literally multiple papers have been written on exactly this task, on exactly this data set. And it's fine as far as it goes. A lot of useful things you can do by doing that. But here, it's exactly what we don't want to do. And the reason is that our whole hypothesis is that KLG might not capture all the pain-relevant features, right? And so we don't want to train a model to just replicate it. We don't want to train a model to just replicate clinical knowledge when the whole hypothesis is that that knowledge might be incomplete. Instead, we're going to train the model to learn from the patient directly by predicting Kuh's pain score. So rather than just training it to imitate the doctor, we're going to train the model to learn from the patient. So to be very concrete, the input to the model is an X-ray of both knees, and the output that the model is seeking to predict is a knee-specific pain prediction, which we term ALGP, for algorithmic severity measure. And if controlling for this algorithmic severity measure, ALGP, narrows the pain gap more than controlling for the clinician severity measure, KLG, it implies that that clinician severity score overlooks knee features, which would help explain disadvantaged patients' higher pain levels. So this would substantiate the in their knees hypothesis. Before I show you the results, are there any questions on the basic setup or anything? Okay, cool. I will continue. Okay, so our first result is that the algorithm does in fact find additional signal for pain in the knee X-ray. ALGP predicts pain better than does the clinician severity score KLG. It achieves a higher R-squared, the difference is statistically significant, and you see similar results for other predictive measures like root mean square, non-parametric correlation, etc. But of course, those R-squareds aren't very high, right? And that isn't the central question of the analysis anyway. The central question is, when we control for ALGP, the algorithmic severity score, does it reduce the pain gap? And it turns out that the answer to that second question is also yes. Here, the first numerical column is just what I showed you before. It says, when we control for the clinician severity score KLG, the pain gap doesn't get all that much smaller. But the second numerical column is new. It says, when we control for the algorithm severity score, the pain gap actually does get considerably smaller. And the final column gives the ratio of the first two columns. So you can see, for example, that for race, The clinician severity score narrows the pain gap by only 9% as compared to 43% for the algorithm, and the ratio of those two numbers is 4.7. The overall implication of this table being that yes, there is overlooked signal in the knee X-ray, which would help explain disadvantaged patients' higher pain. So this does substantiate the in their knees hypothesis. Now, neural nets, honestly, always kind of make me vaguely queasy. This comment will probably fly better in a stats audience than in a computer science audience. I mean, I just find them kind of terrifying, right? Because they're incredibly high dimensional, nonlinear, very difficult to interpret models, and you should never sort of take the results purely at face value, even if they look like what you want. So I'm not going to talk through the robustness checks we did in enormous detail, although you can ask specific questions if you want to. The robustness checks took a lot longer than generating the main results for the paper. In brief, we checked things like, is the model, if you just built a BMI predictor, if you train the model to just predict something correlated with pain, correlated with socioeconomic status or race, easily detectable from the image, but not very clinically interesting? No, that doesn't appear to be the case. Did you train a model to just predict race or socioeconomic status? No, it doesn't appear to be the case. The model appears to generalize across imaging sites. We're not learning something specific to one X-ray machine. The model doesn't appear to be just outperforming KLG by virtue of the fact that it's continuous and KLG is categorical. It doesn't appear to be just beating KLG, but maybe there are other clinical indicators which are better. And it doesn't appear to just be learning other reweightings of known image features. We can talk more about any of these if you're curious, and I can talk about them in more detail. I do want to mention two other accessory results, though. The first is that having a racially and socioeconomically diverse data set contributes to our model performance. So this has long been a question in medical studies, like, if we train our model, if we do our study, for example, like, let's say we do a genetic study only on people of European ancestry, as people often do, or let's say we remove all women from the data set because menstrual cycles are annoying or something like this. Does this limit the generalizability of our studies? So we want to sort of assess this. And the specific experiment we do is we compare training the model on a non-diverse train set, from which we've removed all the Black patients, to training the model on a diverse train set, from which we've removed the same number of non-Black patients. So the size of the training set remains constant. All we're altering is how racially diverse the train set is. And what we find is that while both models outperform the clinical severity score, using a diverse train set does contribute to a further boost in performance in terms of R-squared and the reduction in the pain gap. And we see similar results for income and education as well. So this implies that, in fact, yes, using a diverse train set is important. The other result we have regards the clinical implications of these results. So as mentioned, the reason we care about severity scores is that they influence the allocation of knee surgery. So we try and do a simulation study to assess how allocation of knee surgery might change. We replicate a previous study where we allocate knee surgery to patients who have both high pain and severe disease, so a two-part criterion. But we try measuring severity in two different ways, using the clinician's severity score, KLG, and using the algorithm severity score, ALGP. And so what we find is that because ALGP tends to give disadvantaged patients higher severity scores, it is in turn more likely to recommend them for surgery. For example, Black patients would be twice as likely to receive surgery using the algorithm severity score, ALGP, as opposed to KLG. Okay, so to summarize this story, we were able to train a deep learning algorithm to predict pain from knee X-rays. And we showed that this algorithm does find overlooked signal in the knee X-ray, which would help explain disadvantaged patients' higher pain, substantiating the in their knees hypothesis. A clinical implication of these results is that disadvantaged groups may be underreferred for surgery. To put this within broader context of work in fairness in medicine, there's been a lot of previous and invaluable work, some of which I've described, on how machine learning methods can increase disparities in medicine. But our work is sort of the more optimistic counterpoint, showing how machine learning methods can also reduce disparities by detecting signal that humans are blind to. Key to our results here, key to reducing rather than increasing disparities, were first, we chose a prediction task that didn't merely seek to replicate clinical knowledge, but to learn from the patient. And secondly, we trained the model on a diverse data set, and we show empirically that that contributes to our results. Any questions before I go on to the second story?
I have one quick question. I'm wondering whether if you know whether the features that the algorithm is picking up, the convolutional neural network is picking up, are things that could plausibly be detected by a physician, or are they like these very subtle patterns that you really do need some kind of like fancy ML model to learn?
Yeah, that's a great question. So this to me, honestly, is one of the most pressing open questions from the paper, because we do a lot of work on interpretability, but a lot of the results are sort of negative results. Stuff like, we haven't built a BMI detector. We are able to use image saliency mapping techniques to sort of say the algorithm is focusing on the knee and on regions of the knee that appear to be clinically relevant, like the tibiofemoral joint space. But sort of precisely pinning down exactly, like sort of trying to verbalize, like what exactly is it seeing in this X-ray image remains an open question that I'd like to collaborate on with radiologists. And I would say even more broadly, this feels like one of the most fundamental open questions in medical imaging at the moment, sort of deep learning for medical imaging. Like, people just wrote a paper showing that you could sort of predict race with quite high accuracy often from medical images, but they basically don't know why. And that's a problem. So it's clearly an area in which we need to make headway.
Thanks. It looks like we also have a quick question from Robert Pickett.
Hi, I was just wondering, a similar question, I think. Is there reason to believe that the features being detected by the CNN would respond well to surgery? So
yes, that's a great question. Sorry, I didn't mean to cut you off.
No, I was just going to elaborate, but I think it came across.
Yes, I think that's a great question. So the analysis of surgery, is based on this simulation study. I think in our data set, one really nice thing would have been to basically take people who received surgery and show, for example, that like people with higher algorithmic risk scores, for example, had better surgical outcomes subsequently. That would at least be somewhat suggestive, if not, dispositive. The data set, unfortunately, doesn't have enough people who received surgery in order to do that analysis. So in subsequent work, I'm trying to set up a collaboration with an organization that has a large data set of knee surgeries, so we could specifically assess, like, is this prognostic for better outcomes in surgery? Yeah, because I think that's a very interesting follow-up question. Cool, great question. Should I go on? Or are we doing on time? We're doing okay.
Yeah, sure, that sounds good. Thanks.
I will continue. Okay, cool. This is joint work with Tim Althoff, Daniel Thomas, Paul Hillard, Yuri Leskovic, and it came out in Nature Human Behavior a couple of months ago. Okay, so cycles in general are fundamental to human health, right? You've got like daily cycles, like your circadian rhythms, your weekly cycles, like you go out on Fridays or you sleep in on the weekends. You've got seasonal cycles, like you exercise more in the summer, you get sad in the winter. And then, of course, you have the menstrual cycle. And the menstrual cycle is itself a very fundamental thing. It's been implicated in a wide range of sort of fundamental health and disease states. But stigma and lack of large-scale data have hampered study of the menstrual cycle. And this has diverse manifestations. So you see it in medical data sets when this data is often lacking entirely from medical records or global health data. You see it in health tracking apps like Apple and Fitbit, which were slow to add menstrual cycle information and did so only in response to popular outcry. You see it when clinicians don't always consider this fundamental aspect of health. And you see it, of course, in a broader culture, which is often stigmatized or mock discussion of this issue. And, this is not some like abstract feminist studies ivory tower issue, right? This results in concrete harm to the health of half the global population. And to be very specific about that, the girl on the left is required to go into that little hut when she's on her period due to stigma associated with the cycle. And like, if you can imagine, requiring young girls to do this, it can be dangerous. Girls have died as a consequence of this. They've been bitten by snakes. They've been sexually assaulted. They've frozen to death or suffocated. And so this is, just concretely a very bad consequence of stigma associated with the cycle. The woman on the right is Noemi El-Haddad. She's a professor of biomedical data science at Columbia. And she's, suffered for much of her life with pain from endometriosis, which is a menstrual cycle linked condition, which is poorly understood as a direct consequence of stigma associated with the cycle. So this is something which like concretely harms real people. So that's a little grim, but there is good news here, which is that women's health apps offer new potential for understanding and destigmatizing this fundamental aspect of health. Specifically, today I'm going to be telling you about data from the Clue Women's Health app, which tracks millions of women across more than 100 countries, and it provides a very data-rich picture of people's daily life, allowing them to track stuff like their mood, their pain, their sexual activity, and crucially, for our purposes, the start of their menstrual cycle. So just to sort of show you what kind of data people can track with this app, this is purely simulated, but it's illustrative. It's simulated for patient privacy reasons. You know, people can track when their period begins, and so the vertical black lines denote the inferred menstrual cycle start, when bleeding starts. They can track their resting heart rate and their weight, so continuous features like that. And they can also track categorical features like sexual activity and social behavior or sort of social emotions and mental state. So we're going to use this data set to provide the first decomposition of female mood, behavior, and vital signs into those 4 cycles I told you about before, the daily, weekly, seasonal, and menstrual cycles, and thereby improve understanding of this fundamental aspect of women's health. Our data set consists of millions of women, hundreds of millions of observations. So each observation here would be like 1 log of happiness on 1 day for 1 woman. 109 countries, and we're going to be studying cycles in 15 dimensions of mood, behavior, and vital signs. So things like happy versus sad mood or resting heart rate. So how do previous studies look at cycles? One thing that people often do is they'll just take an average across the entire population. So this shows a study published in Science about a decade ago. They're looking at happiness as inferred from Twitter data. And so happiness is on the y-axis, or inferred happiness. And basically what they're doing here is, you know, to get the value at 3 p.m., they're taking a population average of all people at 3 p.m. And you can see that, like, this is pretty revealing, right? You know, you can see sort of daily patterns and weekly patterns and so forth. This shows another analysis of Twitter data, you know, over a longer time period. So this is several years, but you can see sort of weekly variability. You can see holidays. You can see maybe longer time trends, et cetera. And, you know, we can do this on our data as well. So this graph now is made on our data. It's made on Clue data, and it's plotting happiness on the y-axis. And, you know, you can see that this view is somewhat revealing. Well, you can see this high frequency fluctuation, which corresponds to weekly cycles. You can also see outliers like Christmas, or the purple dot is the day after the 2016 US election, which makes sense given that this is a predominantly female, international, and young population, that they would be feeling kind of down on that day. But there's a problem with this view as well, right? This approach is valuable, but an obvious limitation is that averaging across the entire population in this way will make the menstrual cycle invisible. Why is this? Because if you take a population average on January 3rd, 2016, you know, people are not going to be synced on that menstrual cycle, on their menstrual cycles on January 3rd, right? They're all going to be at different points in their cycle. They're going to be out of phase. And consequently, you're going to fundamentally make this fundamental source of variation invisible. And it turns out that this is quite important. Here, the red line plots the counterfactual, where you could actually observe the menstrual effect. And I'll show you how we get that red line in a little bit. The point being that, like, this is a substantial source of variability, which is being rendered invisible by merely taking an average across the entire population. In particular, the amplitude of that red cycle is comparable to the Christmas effect and to the US election effect. Fine. So we need a better method, which is going to actually enable us to see all 4 cycles, even cycles like the menstrual cycle, which are not synced across the entire population. So we're going to use the multivariate regression in order to decompose the overall signal into 4 simultaneous cycles. Specifically, we're going to regress each observation, mood for one person at one time point, on categorical variables which encode the 4 cycles. So we're going to have one categorical variable for the hour of day, like 3 p.m., one for the day of week, like Sunday, one for the month of the year, like December, and one for the day of the menstrual cycle, like 3 days after the period. And then the regression coefficients are going to capture the cycles. That's a little abstract, so let's be a little more concrete. Here's an illustration of what this method gives us for happiness. So now what I'm doing is I'm plotting the regression coefficients on the y-axis. Each graph corresponds to one of the 4 cycles. You can see menstrual cycle, daily cycle, weekly cycle, and seasonal cycle. So you can see, for example, that there's a substantial dip in happiness immediately prior to the period start, consistent with previous work showing sort of premenstrual dysphoria. You can also see sort of that mood declines in the middle of the night. You can see an increase on Saturdays and Sunday, and you can see sort of a drop right near the start of the school year, which may be somewhat idiosyncratic to this data set because it's like a sort of a young school age population. Okay. And another important feature of this graph, which emerges, is that the menstrual cycle happiness amplitude is actually the largest of these 4 cycles for happiness. The overall implication being that this is why menstrual data is important. Without it, you render the largest cycle for this dimension totally invisible. This isn't just true for happiness, incidentally. The menstrual cycle has the largest amplitude for 11 of the 15 dimensions of mood, behavior, and vital signs that we study. In particular, it's quite large for many mood dimensions, for sexual behavior, and for all 3 vital signs. It's not the largest for every cycle. So productivity, for example, the weekly cycle is very large because everyone thinks they're unproductive on Sundays. Another thing we're able to do by virtue of the large size of our data set and sort of the national, the diversity of nationalities, is we're able to show consistent directional patterns across countries and cultures. So consistently, people get fatter prior to their period start across all countries in our data set. And this is useful because previous studies have often been conducted on 41 unmarried young women from Smith College or something like this. Like they're highly specific small samples. And so it's been a little unclear how much their findings generalize. Okay, so let's be very clear about what we're not saying with these results. In particular, we are not saying that women are more volatile. Why? There are a couple of simple reasons for this. The first is that our analysis makes no comparison across genders or sexes. We're literally not able to do that. We don't have data on gender or sex in our data set. Secondly, previous research does not find sex differences in volatility. There's this wonderful paper entitled "Female Rats Are Not More Variable Than Male Rats" by some researchers who I think were probably quite annoyed with this trope. And the reason that this is true, right, is men have hormone cycles as well. They're just, somewhat less documented in popular literature, and it would be an interesting follow-up work to study them as well if we could find the data. And the other is that cycles aren't the only source of volatility, of variability in human mood, behavior, and vital signs, right? If your favorite football team loses a game, that's something we don't study at all in our analysis. And so there are many other contributors to human volatility besides cycles. So what, in fact, do our results show? To put them in larger context, stigma and lack of large-scale data have hampered study of the menstrual cycle, but this is actually a primary contributor to cyclic human variation. It's comparably large for many dimensions to the much more studied daily, weekly, and seasonal cycles. And as such, it should be normalized and studied and talked about just as, the sleep cycle is. It should be just as normal a part of human health and existence. And the good news is new women's health data sets offer the unique new potential for understanding it. I should mention, by the way, this is only one of several papers we've written on this topic. You can find our other papers on pregnancy and on sort of modeling individual cyclic variation published as well. Cool. Any questions about that before I go on to the final story? Great. All right, so yes, with our remaining time, let's talk about disparities in COVID. This is joint work led by Serena Chang, and then also with Peng-Wei Ko, Jolene Gerardine, Beth Redbird, David Grusky, and Yuri Leskovic. It's quite an interdisciplinary team, which is pretty important, I think, for studying COVID. Yes, consisting of sociologists and epidemiologists, and of course, computer scientists as well. Okay, so as you know, viruses like COVID spread through human contact, which is to say that there is an underlying contact network that modulates the spread of the virus. Specifically, there's, under simple epidemiological models, an infected person has some probability of infecting anyone she comes into contact with. Those people then infect their contacts, and you get the explosive spread of the virus across the human contact network. Consequently, understanding the structure of this contact network is very, very important for modeling the spread of a virus. But current models tend to rely on simplistic estimates of the underlying contact networks, because of course it's hard to know who everyone comes into contact with. For example, you might assume that anyone can infect anyone, so the network is fully connected. Or you might use a network that captures trends at a very high level. For example, a network which connects city to city via airline routes. It doesn't tell you anything about movement within individual cities. Or you might use, for example, historical data. You might say, look, I have a granular picture of people's movement in 2016. Hopefully that still persists in 2020. But it's easy to see why these empirical strategies might be insufficient. A first reason is that we're undergoing or have undergone an incredibly dramatic change in human mobility, right? You know, you've got stay-at-home orders, you've got reopening policies. Like, hopefully we will never see anything this crazy again. And secondly, the kinds of policy questions we want to ask often depend upon mobility in a very fine-grained way. For example, we might want to know about the impact of fine-grained mobility policies, like what happens if I reopen bars, but only 30% and only on alternate Saturdays. Okay, that would be like a weird reopening policy, but you understand what I mean. Or we might want to ask, you know, why were poor neighborhoods in New York getting infected at much higher rates than rich neighborhoods in New York? And if you want to ask that kind of question, simply assuming that people interact uniformly or using a network which connects people at a very high level but doesn't capture anything about inequality and movement patterns within metropolitan areas will not be sufficient to shed light on that question. So in our approach is twofold. First, we're going to use cell phone data to try to estimate the dynamic human contact mobility network. And secondly, we're going to put an epidemiological model on top of this network in order to model disease transmission. So let's talk about each of those steps in turn. So our mobility network is going to capture visits from neighborhoods to places. And by neighborhoods, I mean census block groups, CBGs. So these are relatively fine-grained census areas where a couple hundred to a couple thousand people live. And by places, which I'll call POIs for points of interest, I mean basically places that people go when they're not at home. So restaurants, grocery stores, churches, gyms, etc. So we're going to capture the flow of people from neighborhoods to places. Specifically, in every hour, we want to infer how many people from a given neighborhood, a given CBG, visited a given POI. So basically, we have one network for every hour. So you could think of this mathematical object, for example, as a list of networks, one network for every hour, or you could think of it as a giant 3D tensor thing, but that's the mathematical object we're going to seek to infer. How are we going to do this? We're going to make use of data from a company called SafeGraph. And SafeGraph, basically what they do is they collect location data from numerous cell phone applications whose users opt into mobility data collection. And then, as sort of part of a public service during the COVID epidemic, they provided an anonymized and aggregated form of this location data. Now, our analysis covers, and I'll give you more details on that in a second. Our analysis is going to focus on 10 of the largest US metropolitan statistical areas. There's no reason in principle it couldn't be extended to the rest of them as well. So that's just what we focus on in our initial analysis. Those areas cover about 98 million people in total. We're going to model each area separately, so we're not going to model the flow of people between New York and Chicago, and that's for computational tractability reasons. And finally, we're going to be studying the first wave of infections in spring 2020. That's because that was the data that was available when we wrote this paper, but in subsequent work, we've shown that many of our conclusions go through on more recent data as well. Okay, so what does the data set actually contain? First, we have metadata for each point of interest, each POI. And specifically, that metadata tells us its area in square feet, which is very important because like smaller areas are more dangerous, how long people stay there, and what type of business it is. Is it a restaurant or a bar or so on? And then we also have data about the number of visits to each place. Specifically, at a fine-grained timescale, so an hourly or daily timescale, we know how many people leave each neighborhood and how many people go to each POI. So how many people go out and how many people come in. Then, at a monthly timescale, we know the actual network of CBG to POI visits, so the actual network connecting the two. The problem is we don't want that at a monthly timescale. We actually want it at an hourly timescale because we want to capture the fine-grained human mobility network. Now, fortunately, there's a machine learning algorithm or a statistical algorithm, depending on whom you ask, which is designed for exactly this setting. Specifically, we know the hourly number of people going out, the hourly number of people coming in, and then we have a noisy estimate, basically, of the network linking the two. So you can think of this as basically a math problem where, we're seeking to infer a matrix for each hour, the network for each hour. And we know the row sums of that matrix, we know the column sums of that matrix, and then we have a noisy estimate of the matrix itself. And the iterative proportional fitting approach is designed for exactly this setting. It says, if you know the row sums and you know the column sums and you have a noisy estimate of the matrix, then I will give you a matrix which is consistent with those row and column sums and subject to that constraint as similar as possible, using KL divergence as a distance metric, to the initial noisy matrix. And so that's what we do. We take IPF, iterative proportional fitting, and we apply it to the original raw data at each hour in order to infer the estimated hourly visit network. And in total, our networks for these 10 cities encompass 500,000 POIs, tens of thousands of neighborhoods, and 5.4 billion hourly edges. That's a little mathy and a little abstract. So to be concrete about the thing we actually get out, here's an example for the Chicago metro area. I'm showing you networks at 2 different time slices. The first from early March, prior to the onset of social distancing, and the second from early April, after social distancing measures have really taken effect. And so the gray line, basically, the gray lines show visits from from CBGs to POIs, and denser gray lines indicate sort of more visits. And so you can see, for example, that the number of visits drops off precipitously from the left network to the right network, which makes sense as social distancing takes effect. You can also see that people mainly hang around their own homes, indicating, people tend to go out to places nearer to themselves. Our networks, by the way, are publicly available if you want to build on our work, replicate our work, and so on. Okay, so that's our network. Actually, any questions about that before I go on? Great. Okay, so now, oh, sorry, yes. Please.
I'm in Manhattan and my office is above an REI. In your network, am I at REI and at risk of getting infected by all the people who
Yeah, that's a fantastic question. So we're dependent here on SafeGraph's attribution of visits to POIs, and that's clearly an imperfect thing. Their ability to do that in 3D space is definitely imperfect. So to the extent that SafeGraph mistakenly attributes visits to one polygon when they mean to attribute them to another polygon, we're going to that will propagate forward into our data. Yes, and it will be a problem. Other questions? Yeah, I'm trying to think specifically what probably would, how specifically would that create an issue? I think basically it will be imperfect because like it's, it might look like basically the area is more crowded than it really is, right? Like you're safe because you're not really in the POI. So we may like underestimate basically we may overestimate the risk of certain areas if there are a lot of people on top of each other.
Yeah, I don't know if that happens more in cities, but when I'm in my apartment, when I'm in the country, my cell phone knows where I am. When I'm in my apartment, if I like misplace my phone in my apartment, which I do shockingly often, and I use another device to find it, it always thinks I'm 4 blocks away, always.
So, in like a consistent direction? Can you
yes, it's always the same place. It's always the same place where it thinks it is. So I don't know if that's a city thing or if that's beyond like me and my phone, but.
I mean, yeah, I assume that's a problem other people have as well. Yeah, I mean, I would say more broadly, cell phone mobility data is clearly imperfect. And there are multiple ways in which it's imperfect, and we have an appendix on this topic, and we can talk about it in more detail. It is also the case, however, that it has been very broadly used in both the social sciences to study sort of fundamental topics like segregation and so on, but also within disease modeling specifically, there are sort of op-eds being like, this is a very valuable source of data for modeling infections. So it's definitely something that comes with a lot of caveats. On the other hand, it seems it clearly represents also sort of an advance above, just assuming uniform networks or whatever.
Yeah, well, what's the counterfactual? Like, what data would you have otherwise, right? And
exactly.
And comparing if you're getting trends, in New York versus some other, like, let's say Dallas, right? Hopefully the large scale trends are going, the general conclusions are going to be kind of on the mark, and you're not trying to predict any individual's behavior.
Right. Yes, and indeed we don't have the data to do that, although SafeGraph does somewhat creepily. Anyway, moving on. Okay, so great, epidemiological model, crash course in epidemiology. At the end of this, you will know roughly as much as I do about epidemiology. This is what you co-author with epidemiologists. Standard epidemiological model is what's called an SEIR model. And under this model, people move through 4 states. So when a disease has not entered a population yet, everyone is susceptible to it. And then, once they come into contact with someone who is infectious, they can move into the exposed state, which is to say they have the disease themselves. They're not yet risky to other people, but they have it. Then after a further period of time, they move into the infectious state. So at this point, they're symptomatic, they can infect other people. They might not be symptomatic, but they could still infect other people. So they're dangerous to other people at this point. And then after a further period of time, they move into the removed state, which is to say, maybe they've recovered, maybe they've died, but at any rate, they no longer have the disease themselves and they can't give it to other people. And the model says, you move through these 4 states, you can't go back to the first state, you can only go forward. Obviously, this is a simplification of real life, but it's also very interpretable and widely used epidemiological model. So what we do is at each time point, we model the fraction of people in each neighborhood in each of these 4 states. So we might say, for example, in CBG4 at hour 3, 96% of people are susceptible, 3% of people are exposed, 0.8% of people are infectious, and 0.2% of people are removed. And then we model sort of the dynamics of that over time. How do we model those dynamics? Well, in order to do that, we have to define the ways that people move through those 4 states. It turns out the final 2 transitions are not very interesting. We just assume, as previous work often has, that you just have some constant probability of transitioning to the next state at a given time point. But the first transition is very interesting, and it depends intimately upon the mobility network. Specifically, we assume that new infections, those transitions from susceptible to exposed, can occur via one of 2 routes. First, in neighborhoods at CBGs, and secondly, at POIs. We assume that each person's chance of getting infected in a CBG is just proportional to the fraction of the CBG which is infected, so sort of, riskier neighborhoods if more people are sick. And our model for how people get infected at POIs is quite similar. We assume that it is proportional to the fraction of the POI which is infected times a POI-specific factor, which captures, for example, that smaller areas are more risky. I'm going to not go into huge detail here just for the sake of time, but feel free to ask questions if you're curious. In order to fit the model, basically what we do is we search over 3 free parameters for each MSA. And those scale basically the infection rate at CBGs, the infection rate at POIs, and the initial fraction of the city which is infected. Every other parameter we just draw from the prior literature to minimize risk of overfitting. And we choose the parameter sittings which achieve the best fit as measured by RMSE to the actual reported daily cases in each MSA. This shows a video of sort of how our model makes predictions over time, but perhaps I'll just skip that for now. Now, does this actually work? Yes, it does achieve a pretty good fit to the actual reported cases in each city. Here, blue is the model predictions, and the orange is the reported cases. And you can see that for the 10 MSAs we study, the overlap is actually pretty good. And we compare to various baselines. And yes, we do improve fit over those baselines. In particular, using a fine-grained mobility network appears to help. But I think the overall point of our model is not so much we have some super duper predictive model, so much as we have a relatively simple and interpretable model that enables us to sort of ask relevant fine-grained policy questions. Stuff like, what was the impact of social distancing? What would have happened if we had, started social distancing later? What would be the impact of reopening strategies if we had, reopened certain POIs later or earlier? How might that contribute to infection? And finally, can we understand the mechanisms which produce these striking racial and socioeconomic disparities in case counts? I'm just going to tell you about that final question. You can find the answer to the other questions in the paper. So we know, right, that disadvantaged groups were hit harder by COVID. And so it's interesting to ask whether our model is able to predict this without being told it a priori. And secondly, can it illuminate the mechanisms that contribute this? And in order to analyze this, we study neighborhoods in groups. So we basically say, how does the top 10% of neighborhoods by income in New York compare to the bottom 10% in terms of predicted infection outcomes and mobility patterns? And we find that our model is indeed able to predict socioeconomic and racial disparities in infections on the basis of mobility patterns alone. So without being told that these disparities emerge, the model naturally predicts that lower income neighborhoods and less white neighborhoods have higher infection rates. It also illuminates 2 mechanisms that contribute to this. Specifically, and this one you may have already guessed, people from lower income and less white neighborhoods were not able to reduce their mobility as much after the pandemic hit. You can see that, for example, neighborhoods in the top income decile were able to reduce their mobility by more in Chicago. And this is very plausibly linked to occupational differences, where if it's harder for you to work from home, if you're more likely to be an essential worker, then you have to go out more and you're thereby exposed to higher risk. A second mechanism is a little subtler, and that's POIs visited by these lower income neighborhoods and these less white neighborhoods were smaller and more crowded and therefore more dangerous. So this means that, for example, if a rich person and a poor person both went to a grocery store, the person from the poor neighborhood would tend to go to a grocery store that was smaller and more crowded and therefore more dangerous. Even in the course of living their daily lives in the exact same way, they were naturally exposed to higher risk. And this recapitulates differences that we know in population density purely from census data. Like there's a correlation where basically like people from poorer neighborhoods also tend to live in denser neighborhoods. Okay, this shows results for Philadelphia. Again, in the interest of time, perhaps I'll skip over this video. But I will say that like a clear corollary of our results is that it's very important that reopening plans consider disparate impact. They don't just consider the impact of the reopening plan on the population as a whole, but specifically on disadvantaged neighborhoods because the infection dynamics are qualitatively different. Okay, a couple caveats which are important. First, of course, our analysis of data is from spring 2020. Our data doesn't cover all POIs. So for example, nursing homes are not well covered in our data. That's a clear caveat. It also doesn't cover all people. If you don't have a cell phone, you're not going to appear in our data. And this plausibly, again, undercovers old people, undercovers children. Our model itself is parsimonious and doesn't seek to capture all real world attributes of transmission. But in subsequent work with sort of a more sophisticated model that seeks to model other things like mask wearing, for example, we show that the high level conclusions still go through. We show that we're accurately able to set daily COVID cases with a scalable and fine-grained model that enables us to ask questions about, what would be more efficient and equitable reopening strategies. And this work has had substantial policy impact. It's been cited by policymakers and institutions, both nationally and internationally. And in subsequent work, we've been working on translating the model into guidance for US and international policymakers through collaborations with the Virginia Department of Public Health. So to conclude, I've told you 3 stories today, which gesture to the point that AI and data science don't inevitably increase inequality. If we're conscientious about where we look and we conscientiously focus on populations we've previously been blind to, we can also potentially reduce inequality by shedding new light on the health of these populations. Thanks very much for your attention and for inviting me to give this talk.
So I'll clap on behalf of everybody for that wonderful talk. Thank you so much, Emma. And I'd like to open it up for questions. And as usual, just particularly encourage students to ask questions. So feel free to either raise your hand or unmute yourself or however you prefer to ask.
If no one's going to ask a question, I'll ask a question. So it sounds like, I mean, you went through it very quickly at the end, but it sounds like people are paying attention on the COVID stuff to what you're doing, and starting to listen. How do you, given like everyone and their Aunt Fanny was like trying to create a prediction algorithm and sell their, analysis, and like, I'm convinced that what you're doing is much more sophisticated and a better strategy than a lot of the other things I've seen. How do you convince a policymaker though? What standards of evidence are they looking at? How do you help them understand why your algorithm is different from someone else's?
Yeah, it's a good question. I'm reluctant to answer this too forcefully because, I don't work directly with policymakers. And so I'm a little, my guess, I guess, is that, they're probably looking to sort of what they would consider reliable sources. Like, okay, the New York Times wrote an op-ed on their model, and so, this is a legitimate thing. I very much doubt they're digging into the, 50-page supplement in the paper. My guess is that they're sort of, they're going off what they would consider reliable sources. And hopefully, those reliable sources are doing a decent job of filtering for stuff which is reliable. Like hopefully peer review is working well here. And so, the papers which are published in good journals are themselves reliable. Although in the COVID pandemic, that's been pretty hit or miss. I mean, I think one thing which is quite personally interesting to me is how can I work from the outset more with policymakers directly, so that you're sort of immediately in the room where it happens, as opposed to relying on someone to be reading the op-ed in the New York Times on the particular day when it's published on your work.
Right, because that could actually
that's
inform what questions you're actually asking and answering, because I think there's a lot of us who end up answering questions that no one cares about, right?
Yeah, very much so.
Right?
Yeah. I guess the other thing I want to mention is, the subsequent project working with the Virginia Department of Public Health is useful because, you are at that point directly talking to people who are trying to give public health guidance. And so you can say to them, oh, how should I set up this counterfactual estimation so it's as relevant as possible to what you're trying to do? And that obviously is, extremely helpful. So you're not asking counterfactuals that no one actually cares about.
We probably have time for one more quick question. If anybody has something. Robert?
Sorry, keyboard shortcuts. So I don't know if you saw this recent sort of op-ed about health disparity tourists, talking about how there are people sort of coming in to do research in this field that's often been dominated by sort of less people not from dominant groups. And now people are coming in and getting all these resources, these new resources, and those people tend to be majority group scholars. I'm just curious how you think about this as it fits, especially with your unexplained pain disparities paper. If the fundamental problem was identifying, like was it KGP or something, was identified on white patients predominantly, is there a concern that we should have about predominantly white scholars addressing measures being produced by predominantly white doctors on predominantly white patients? Do we need to be thinking about how to diversify our sort of author pool as well to look for these sorts of things? Would that have caused you to look in different directions, do you think?
Yes. Yes. I think the answer to all of that is obviously yes. And I will say personally, I'm more comfortable writing papers about the menstrual cycle than I am writing papers about, racial pain disparities in knee osteoarthritis. I think any conscientious person would probably feel that way. And obviously increasing the diversity of the author pool is pretty essential. On the pain paper, we actually originally started by looking at socioeconomic pain disparities, and then my instinct was to look at gender pain disparities based on sort of stuff I knew about that. And then I was like, oh, we should probably also look at racial pain disparities, which became the eventual focus of the paper. So it's obvious, I think, that one's background can influence the questions that you find salient and the things you choose to focus on. And yeah, we're like pretty clearly massively currently failing on that. And I think it is influencing our science. And this is not also just my anecdotal impression. Like, this is well substantiated by the research showing that, an author's demographic background does in fact, influence their perspective and the subfields they choose to focus on. And so, yeah, I think this is a pretty settled point. Yeah. All
right. Well, I guess we got to wrap it up here, but let's thank Emma again so much. Everybody. Yeah, hope everybody has a great day. Thanks so much.
Thank you.